Perfect. Good afternoon all. My name's Jonathan and I will be acting as the moderator today. And I'd like to welcome you to our dementia capable care offering, an enriched model of support to mitigate the behavioural and psychological symptoms of dementia. Chris, our speaker, will be using the acronym BPSD just to save some time today. So that's something you want to familiarise yourself with. Handing over to Chris, our Senior Vice President. Today, we'll be having a 30-minute talk and then a 15-minute Q&A. If you put questions in the Q&A or chat box, we will get to them all at the end. Over to you when you're ready, Chris.
Thanks, Jonathan, and thank you everybody for dialing into the webinar. As I'm in full presenter mode, I won't be able to see any of the questions that are posted. So Jonathan will keep a tab on that, and then he'll kind of bring them to my attention at the end. And all being well, we'll be on time in terms of 30 minutes and then 15 minutes Q&A. So let's get started then. So just the agenda for the webinar is, I'll just set a current context of why we've decided to focus on dementia and why that's an important aspect that affects health and social care services. I'll then go into a bit more detail of what we mean by the behavioural and psychological symptoms of dementia, before then looking at an enriched model of support. What does that look like and how does that help to mitigate those symptoms? I'll touch briefly on the dementia capable care training package, just very briefly right at the end, and then there'll be opportunity for questions. The webinar is being recorded as well, as you will have been given that information when you join, so you will be able to have access to play this back later. So dementia, as you know, or probably most of you know, is an umbrella term for a collection of symptoms which can include memory loss, but also it affects problem solving, language. It also affects and creates changes to people's mood and behavior. You know, that if you take the average, the kind of average person on the street, they probably associate dementia with memory loss only, but it has far-reaching implications than just memory. And again, to take the average person on the street, probably familiar with the term Alzheimer's disease. But again, that's only one type of dementia. There are various other types of dementia, each having a slightly different impact on the person. And why is this important? We know from the evidence that as populations age and as people live longer, then there's an increased likelihood that there'll be more people living with dementia. And it's estimated around the world that within the next 10 years, that percentage will reach about 75 million of the entire population. And again, if we just kind of think of maybe Europe, it's estimated that will be around 10 million people. And in the UK, it's estimated that currently there are around 920,000 people living with dementia to some degree. And that just in the UK, that costs the taxpayer approximately £26 billion per year. So not only does dementia have a significant impact on those people and families of the individuals living with dementia, it has a longer term impact on health and social care services, and ultimately it has a tremendous burden on the taxpayer. And as a result of this need and the growing demand for care and support and the increased burden on the taxpayer, most countries have produced dementia strategies. So whether we look to the UK, so there's a strategy for England, Wales, the Scottish Parliament have got one, the Republic of Ireland and Northern Ireland, in America, the work we do there, there's various dementia strategies state by state, Australia, New Zealand. because it's affecting so many people, most governments have now come up with a strategy. And one of the common themes or objectives that we see in these strategies is the overall ambition to provide better care and support, not just for people living with dementia, but also for their families. And what we know about people living with dementia is at one end, you've got people who need high levels of care and support, and that comes through the health and social care services. But we've also got a lot of people living with dementia who are helped and supported by families, unpaid carers as well. So having an approach which improves the support we offer to individuals and the families is central to the dementia strategies. From a professional perspective, for those people who work in health and social care and those people who are supporting specifically individuals' dementia, part of the strategy is also making sure that people have the right knowledge and skill, not only to understand dementia, but to understand the impact it has on the person. When we start to dig deeper into the statistics, we know that if we just use the UK, the 920,000 people who are estimated to live with dementia, we know approximately 40% of those people will require some kind of care and support beyond their home. There comes a point in time with that journey that an individual just can't get the right support in the home, and so they need some kind of longer term, whether that's a residential or nursing home kind of environment. And of the 40% of those people who find themselves in a longer term care setting, what we also know from the research, that 80% of those people are likely to experience behavioural and psychological symptoms. And fairly logical really is, as the person's journey of dementia progresses, as that has a greater cognitive impact on the individual, then it makes sense that those people are more likely to experience those symptoms. And what are those symptoms? There's a whole range of symptoms that people experience as part of the cognitive impact and changes that are caused through dementia. Again, these are from some recent research, the kind of figures I was able to pull out, and things range from obviously depression, anxiety, through to psychosis, sleep problems. So we know dementia affects people in lots of different ways, and certain things are more common and certain things are less common. But it's not just this memory loss that the average person on the street associates with dementia. It really affects every aspect of the person's life. And as a result, that in turn affects how carers, whether those are paid carers or not, how we understand the impact and how we support the person to mitigate these side effects. Because one of the challenges I think we have is to try and maintain the person's quality of life, and also to try and minimize and mitigate these symptoms. And early models of dementia care really positioned these symptoms as a result of the interaction between the person's cognitive capacity. So where's the individual on their journey, and how does that then impact with their interaction with their environment? And the basic model was the person's cognitive capacity leaves them in a stressful state, unable to cope with the daily demands of life. So an example of that kind of model of dementia would be, you run a hot bath, and then you kind of test it with your hand, or you go for stand in the bath. It's hot. We would simply take your foot out, bring your hand away, run a bit more cold water in, get the temperature right. Whereas a person with dementia, when faced with that same situation, because of the way it's affecting their cognitive abilities, may react in a very distressed way. So may shout or may get angry, might bang against the bathroom wall or door, because they're just unable to process how they interact with their environment. And this model suggests that those challenges become more progressive as the person lacks, through those cognitive challenges, the ability to cope and respond appropriately. So in effect, it becomes like a stress overload. However, for those of you familiar with the work of Thomas Kitwood, he took a slightly different approach. He recognized the cognitive impact on the person, how they interact with their environment. But he suggested there's another piece that's really important, and that's what he described as personhood, is that need to be very person-centered and not just understand the cognitive implications and the cognitive challenges that arise from dementia, how the person interacts with the environment, but he was more focused on really knowing who the person is also an important part of mitigating the behavioral and psychological symptoms. So recognizing it's not just the dementia, it's not just the cognitive impact, but it's understanding who that person is, their journey, their life, their relationships, and then how an enriched environment addresses all those elements together and not kind of sees them as separate. Why should we bother to address the behavioral and psychological symptoms of dementia? Well, first of all, we know dementia anyway, as a progressive condition or disease, will start to impact on the person's quality of life. It will start to affect their relationships. It will change the relationships that person has with their loved ones, family members, and friends. So we want to try and maintain the person's quality of life as much as possible through their journey. And if not, we know that starts to have other effects. We know that people with dementia are more likely to require further hospital care and treatment, may be more vulnerable to things like falls, may not eat and maintain nutrition and hydration in the same way as they would otherwise. So again, we start to see that dementia starts to impact on all aspects of the person's quality of life. We also know that because of those symptoms, those people who care and support their individual have to represent the impact to healthcare and medical professions. So it's not untypical that we see people with dementia being prescribed antipsychotics and sedatives as the carers struggle to support the person and to alleviate those symptoms. And again, we know that just with dementia alone, it's estimated that accounts for 1,600 more strokes per year than somebody without dementia, and accounts for something like 1,800 deaths per year. And the other interesting fact is there's a 200% increase in cognitive decline when somebody's diagnosed with dementia than when somebody isn't. So it really does start to impact on people's life. As people move into care, we also see some practices becoming restrictive because staff get anxious about the person tripping or falling, fracturing a hip or femur. So again, some people might remember the Panorama documentary that was on a few years ago, which showed really poor care and support being offered to people with dementia. And again, the image there of a bed rail. A bed rail's great if you're at risk of rolling out of bed because you've got no coordination. However, we also, and certainly I've been aware of a bed rail being used not as a means of safety to prevent somebody accidentally falling out of bed, but as a means of stopping somebody getting out of bed because there's fears and concerns the person then might wander or trip or fall and hurt themselves. So often good intention, but arguably starts to have other impact factors on a person's quality of life. And then we also know that people with dementia are subjected to other restrictive practices. Common things we see now in modern dementia services is the use of electronic equipment, whether that's to give access to and from certain parts of the building, or even people who are wearing electronic devices in order that if they do go for a walk and then find themselves lost and not knowing how to get back home or get back to where they're living, people can track them and find them. And again, so all these elements start to impact on a person's quality of life. So I guess really what the research is now saying is these behavioral and psychological symptoms are not necessarily an inevitable outcome of dementia. Instead of saying, well, this is part of the disease, this is what happens, what the research is now saying is the symptoms are more likely to occur if we don't provide enriched support. If we're not looking at the person's dementia, how it impacts on their cognitive abilities and their functioning, and if we're not seeing the challenges of the environment in which they live impacts on them, and if as staff we don't understand that person, their relationships, what's important, and then make adjustments, then these symptoms are more likely to happen. But if we really think about supporting people in an enriched way, we're more likely to mitigate and minimize these symptoms. And by doing so, that's going to improve people's quality of life. So that's very clear in the research. So I just want to share an illustration of how an enriched model can actually really make a difference. So I'm just going to share a story based on somebody who is real. His name isn't Joe, and that's not his real picture, but I just wanted to give an illustration of what a difference staff thinking of an enriched way of support can make to an individual. So Joe has moved from home to live in a dementia care facility. He's become increasingly confused, and especially at night, where his confusion appears to be at its greatest. He'll often get very agitated during the night. He doesn't sleep. He comes out of his bedroom. Sometimes he's dressed, and sometimes he's partially dressed. Sometimes he's not dressed at all. He's naked. He wanders around the home at night. He'll sometimes go into other different rooms, or he'll even try and go to somebody else's bedroom because he gets confused. And staff get really anxious about this, and they'll try and ask him to go back to bed. He insists he's got things to do. He's got important things to do. There's something that he feels he has to do, but he can't articulate that to the staff, and the staff can't understand what it is he needs to do. And when staff tried to guide him back to his room, or if they try to, for example, put a dressing gown on him, or if he's not dressed at all, Joe gets very aggressive and hostile. He'll push past staff, and he will strike out. He's actually injured 2 staff, and so staff have become quite wary of him. If they try and encourage him back into bed, he gets very, very angry, and the staff ended up speaking to the healthcare professionals, and the doctor has prescribed him some sedatives to try and help him with his sleep, and they're monitoring how he responds, and they're considering whether or not to use antipsychotic medication or other medication to try and alleviate some of this distress. And I guess it wouldn't be untypical for staff to describe Joe like that. They'll talk about how he wanders. They'll say he can't dress himself. He's often naked. His sleep's disturbed. A whole range of ways in which staff might describe Joe. The one thing I've highlighted is, you may be familiar of the report by Hebram in 2016, which described longer term care facilities for older people, and particularly older people for dementia, as God's waiting room. It's almost like, he's no longer Joe. So there's not much hope. His quality of life is so poor. And then also, not only remembering Joe, we have to think about the family And again, for those of you who work in this environment, you'll be familiar with that family sometimes expressing two bereavements, you know, that feeling of the person's been lost and this family can't cope anymore. So when they move into a care facility, that kind of sense of loss. But then if eventually when the person dies, there's a secondary bereavement of the person. So what an enriched model tries to do is just look at this in a slightly different way. And the three aspects of an enriched model. The first aspect is to work in a trauma informed, person-centered way. And that's really recognizing who the person is, their history, and recognizing what they will do. What are their motivators? Because those motivators will still exist. The second bit is then to recognize that the person's type of dementia is going to have an impact. It's going to have a cognitive impact on a whole range of the person's life. And so by using an abilities-based approach, we can still determine what the person's able to do for themselves. And then finally, by looking at the first two issues, what the person will do and can do, then we can make adjustments to the environment. We can adapt our approach. And that's what we call the may do. So we could encourage people to do things for themselves to the best of their abilities. If we're able to adjust our approach, adjust the environment, and we base that on the will do and the can do. So it's a fairly simple philosophy that underpins the model: will do, can do, and may do. So I'll just talk very briefly through that. So using Kitwood's person-centered model is the will do really is about who that person is, their life story, their history, their relationships, understanding their likes, dislikes, preferences, qualities, gifts. I remember doing some work in a dementia service, and I said, could you describe somebody you work with? And they give us the list I showed you about Joe. We work with people who wander, who are confused, who get aggressive and can get really hostile at times. And my response was, if I want to describe somebody with dementia who I work with, I would probably say mum, dad, partner, lover, teacher, shop worker. The last thing I'm going to describe them as is a list of challenges. I want to describe who that person is at the core. And that's really what Kitwood was on about, is knowing the person, knowing their preferences. And the point I put there is understanding what's a good day and a bad day. And if we go back to Joe, you can see probably his good day is not to be kind of pressured to go into his bedroom and sleep at night, because he obviously is up and about at that time. So, a good day would be to allow him to kind of do what he needs to do in the evening or at night time. A bad day is to be pressured to go back to bed and to get back into bed or to get dressed. And sometimes what's right for the person conflicts with what's right with others and what's right for staff. To have somebody up in the middle of the night might be right for them, but if they are then trying to get in other people's bedrooms, that's not right for those people who are asleep. Likewise, if you're working in a care facility and a manager came round, I think there's a chance a manager would say, why is Joe up and about and dressed in the middle of the night? So I think the enriched model starts to challenge people's practices and rituals and routines, which are based on the way the organization is facilitated, as opposed to how we tailor care to the individual. So I think there's things to think about for an organization around being truly person-centered. And for some reason, my screen's frozen. Hang on, let me see if I can. Okay. The next bit is we look at capabilities and limitations. We know that the person's dementia and how it progresses will start to impact on the things a person can do independently, but also it still leaves remaining abilities. So an enriched model, we use the Claudia Allen cognitive model. so that we can understand an understanding of where the person is on their journey. And that tells us what realistically are the individual's remaining abilities, or as Claudia Allen called it, best abilities to function, the BATF. That's really, really important in terms of maintaining people's independence. And again, if you're not familiar with Claudia Allen, she developed a cognitive disabilities model and described the different levels, the journey in which the person will go, and how the dementia affects them at different points in time. And this notion that function is based on sensory, physical, emotional, and cognitive ability, with cognitive ability being the critical factor and how that impacts on all other aspects of the person's day-to-day living. So using that model is really, really important, so as we know how to pitch the right support. And also knowing the type of dementia the person has is critical for frontline carers, especially those carers who haven't got professional qualifications and training. Is just knowing that each dementia is slightly different in its journey, the path it takes. So just give you the Alzheimer's is a fairly steady curve over time, where we see increasing cognitive decline at a fairly steady, even pace. But if you compare that, say, to Lewy body, we can see over time the progression of that dementia is very erratic, very changeable. And that's important for frontline carers to know, because often what can happen is with something like Lewy's body, somebody can do something today, but tomorrow they can't. But then a couple of days later they can, and then suddenly, for the following next week, something else changes. Vascular dementia, again, carers knowing that is important. So people can function at a certain level for a while, and then suddenly there's a step down decline in abilities, but then that levels off again. So using a mixture of the cognitive disabilities model that Claudia Allen developed, understanding the type of dementia the person has, really helps staff to know what abilities the person has remaining, what support can be tailored to maintain that person's quality of life. And then we'll move around to knowing that information allows us to adapt and personalize the environment and the support we offer to people. And then fundamentally, that leads to our individual approach. And that's making sure we give people meaningful engagement, adaptive engagement, maximizing the involvement of key relatives and personal relationships to enrich the person's experience, really. All those things factor into quality of life. So, no surprises then is if you take an enriched approach to Joe, we focus on his remaining abilities, we look at the support he needs, we remember first and foremost that this is Joe. Joe's lived a life. We engage with relatives. We understand that we discover he spent his entire adult life working night shifts. His pattern of lifestyle is he tends to nap in the day, he tends to be a bit more active at night. Hence, that accounts for why he might not be in bed. Suddenly, we start to discover that what he does, his behavior, is telling us something. It's a means of communication. And as we start to uncover that and discover how we can mitigate both the behavioral and psychological symptoms of dementia and how we start to tailor support around him, it's less likely that we'll look for sedatives and antipsychotics as a means of managing the behavior, because ultimately, for example, an antipsychotic doesn't work on behavior that doesn't have a psychiatric origin. What it does is sedate the person and impacts on their quality of life. Creating a supportive social environment is important, and developing and maintaining relationships is really what maximizes the person's quality of life and involving the family. So a slightly different approach, a slightly different model can really make an impact for the person. So that's kind of very quickly an overview of what an enriched model of care is and what dementia capable care is about. I guess before we go to questions, I'll just finish on, well, what does that mean for you and your organization. We've actually, off the back of the Dementia Awareness Week last week, we've been working for the last 12, 18 months on this package. So we now offer it as an instructor program. So you can come and train as an instructor. We'll give you all the resources and materials, and then you can go and train your staff in your organization if that's something you're interested in. And I guess that brings me to the end of the webinar, and happy to take any questions people might have.
Chris, we've got about 4 questions. We've got a mixture of technical questions about the course and how it's delivered, okay, and then more based around the research and the topics that you brought up. So I'll just fire them out as they come in. Okay. How long does the training course take, and how do I actually end up delivering it to my staff?
Oh, okay then. So the first bit is we train instructors who then go into their organization and train their staff, because that gives the organization not just the greatest flexibility on delivery, but it's the most cost-effective way. One of the things we know about services that provide support for people with dementia, it's the poor relation. You know, they tend to be really underfunded. It's very difficult to get the resource to train staff. So we offer an instructor model because we think that maximizes an organization's ability to get that training to their frontline carers. So the instructor course is a virtual structuring course. So you would come and do our online program, which will give you the underpinning knowledge and skills around an enriched model. Then you would come into a live virtual class where we will take you through the program, look at some application points, get you familiar with the content and how to deliver this. We'll provide you with all the resources and materials, instructor guide, learner materials, access to all the online course. Once you're certified as an instructor, then you can roll that out to your staff. Now, then when you get to the rollout, 2 ways of doing this. The most efficient, cost-effective way is your staff go through a blended learning event, by which I mean they'll do our online course first, gives them the knowledge and the skills at the core of what is an enriched model. And then you bring them into the classroom for half a day and you get your learners to apply that knowledge to their working environment. You could, if you're not geared for that kind of blended approach, you could teach the whole package in a classroom over a full day, but it is designed for maximize efficiency with the online plus a half-day class. So that you ultimately will drive that as the instructor. It'll be totally your choice, but to be an instructor is an online course followed by 1-day virtual class, and then we give you everything you need, materials, resources to support you to deliver that to your colleagues, your staff in your organisation.
That was a private panelist chat. It's also the same question that I can see from Simon. So Simon, if you let me know that I've answered your question. The next question is, does a person who uses sign language as a mode of communication, when that is affected by dementia and they forget to sign, how difficult is it to communicate when this happens? And I guess, Chris, to feed it back to what we're talking about today, can this training help in that regard?
I would say if anybody gets dementia, then we know dementia impacts on cognitive ability. And as one of the core aspects of function, cognitive ability, if it's impacted by the dementia, will include things like memory loss, problem solving, language difficulties. It affects people's mood and personality. So if that was to affect me tomorrow, that's invariably going to impact on the way I communicate. And because I'll find it harder to communicate and express myself, then people around me who know me might start to struggle to understand what it is that's affecting me. If I happen to be a person who either uses sign language, whether that's in addition, whether, I've got some hearing loss, so I use some speech, some sign, whether I'm deaf and I rely on BSL as my first language. I haven't got English as a language. That's going to affect my ability to sign. And certainly my experience is working with people who already have an intellectual disability. I certainly worked with at least 3 people who had Down syndrome and had already got an intellectual disability, but as they aged, they also got dementia. And that was particularly challenging because they already had some cognitive challenges to communicate effectively to others. And then that became, if you like, magnified by the dementia. And I guess I'd go back to the point when I give the example of Joe, is that what you really want frontline carers to understand is what we're seeing is symptoms, behavioural and psychological symptoms of the cognitive impact of dementia. So if we view all behaviour as communication, then we can start to work as a team to understand and try and formulate an idea. What does that communication mean? And that's starting with, what do we know about the person? What can the family tell us about the person? And kind of almost doing a hypothesis. If we think a person might use a particular sign to mean something and they no longer use that sign because of the dementia, are they trying to communicate that in a different way? And there's a bit of testing and trying to understand how we adapt our response. I hope that's a reasonable answer for whoever posed that question.
That was from Rose. So if Rose, let me know if that's a clear answer, or otherwise we can always come back to it. Chris, I'll ask you some of the shorter questions because we've got one more technical one. So I think some of these will be quite quick. Is the course mostly designed for carers, or can any member of the staff become an instructor?
Anybody can become an instructor. What we would say to an organisation is just think carefully who you want to nominate as an instructor. So we have people who come on our instructor programs who've got a string of qualifications. They're very experienced, very knowledgeable professionals, but actually when they've trained to be an instructor, don't have time to train. Their role just doesn't allow them to be released. We also have people who are very knowledgeable and skilled and great in the workplace, but actually they come on an instructor course, but they don't like teaching, so they'd rather not teach the program. And then at the other end of the scale, we've had people who've got no actual formal professional qualifications who are superb instructors. They're actually quite good at teaching naturally. So it's important that the organisation chooses who they think is going to make a good instructor, making sure the person has the support and the space in their role to be released to train. The other thing I would say is once you come and do our instructor program, we've done quite a lot of the heavy lifting. We've created all the resources, all the materials. There's a step-by-step instructor guide. We've created all the learner materials. We've done all the research, so it's all based on all the current evidence. So in some respects, once you've trained as an instructor, it's a case of pick it up and go. And then what you're doing is you're enhancing and building on the knowledge and skill of your workforce. So again, if you've got a service where you have direct care staff with very little skill and knowledge, and at the other end of the scale, you've got very experienced nurses, this program will help all those staff. It will add to everybody, regardless of their role.
Great. And then, Chris, we've got 3 questions, one short one, and then 2 research-based ones. So the short one is, do I need to do an annual retraining once I am certified?
Yes, once you're certified, we would ask you to come back and recertify. And the purpose of that is to bring you back to the content, to give you an opportunity to review if the program itself has changed, if there's new evidence, new research, new strategies. If we're going to enhance the program that way, it gives you an opportunity as the instructor to be familiar with that. And also an opportunity to meet up with other instructors and to share your experiences, to make those connections, and through that kind of annual recertification, again, you might build relationships with other instructors. You might then create opportunities to go and see how they deliver the training, see what impact it's having on their service. So the whole point is really not just a kind of certification issue and maintaining competence. It's we really want instructors to build and be part of a community of practice and to share good ideas and experiences with one another.
Thanks, Chris. And then back to a research-based one. Would you say early childhood trauma could result in a bigger chance of suffering dementia in later life?
Ooh. Now, I haven't personally, when we were developing this program, we went back probably 30 years to look at the research and to make sure everything was as current as we could possibly make it. Now, I'm not off the top of my head. I can go back and look, and we can take the person's name, Jonathan, and I can forward information. But I can't recall anything specifically saying if you've experienced early trauma, then there's a greater likelihood you'll have dementia. But I think it's reasonable to assume we do know that particularly early lifehood trauma experience has an impact on the development of the brain, and we know that that impact affects the amygdala in particular and hippocampus. So you get a strong emotional connection and memory to certain events, which kind of creates a fight-flight scenario for people. That impacts their, if you like, the executive part of the brain, their decision making. So I guess if somebody's experienced that in early lifehood, we know they're more likely to have certain traits as they grow. You know, we know that there's a significant number of people who have mental ill health, possibly have got an increased likelihood that they've had trauma in their life early on. I would expect there could be a relationship there, but I'm not.
I've taken down the name, Chris, so I'll forward it on.
I can't, nothing specific, but I think it's a reasonable thing that might be possible. But what we've done is we've built in trauma-informed on the basis that trauma-informed care is a universal approach. In other words, if we just take a trauma-informed approach with everybody, then for those people who've been impacted by trauma, that's going to be really, really important. And for somebody who's not been affected by trauma, it actually will still be good for them as well. It doesn't make a difference if you've not experienced trauma to if you have. So again, we just felt it was really important by being trauma focused. We're actually getting staff to work in a particular way that's beneficial to everybody regardless. So even if the research isn't there, we just felt it seemed like the best approach combined with that centeredness and this notion of personhood that Kitwood talked about in his research.
And then just a final question from Angela. Can I ask about the approach to prevention of dementia? For example, vitamin B testing, as without the correct amount of vit B, can be a killer and affects vital parts of our brains, body, nerve endings, blood flow, which is all connected to dementia.
Yeah, we kind of looked at a lot of things around prevention. We know that lifestyle factors, exercise, cognitive exercises as well as physical exercises, maintaining social contact. We know there are lots of factors that play a part in why dementia may happen, or certainly how we might slow the progression of dementia. And I know there's some research, I think there's been some research looked at noticing changes in the back of the eye. And these various things that are happening at the moment that are looking to, along with drug therapies, of how we can minimize the chances of a person developing dementia in the first place, how we can slow the progression of the disease. I guess what we decided to do with this package is focus on how do we create a model, a very simple model that frontline carers can use when supporting somebody with dementia, with a focus on mitigating those behavioral and psychological symptoms. So that's really the focus of this particular program.
Great. And then just to cover a question I actually answered during the talk, will the slideshow and recording be sent to us? Everybody who signed up and attended the event will receive a recording of the event, and that will be sent to you by our organizer, Alison Lawton. I think that's us 2 minutes over scheduled time.
Oh, that's quite good.
So that's not too
and
bad.
I guess that my parting point would be is over my professional career, which spans 30 plus years, there are people I've worked with who naturally work this way, who are naturally person-centered, who naturally understand that communication and behavior are the same thing, who naturally make adaptations to how they support people, regardless of whether it's somebody with dementia, somebody with an intellectual disability, somebody with mental ill health, you know, whether they work in any setting. But that's the people who are natural. What this course does is, instead of relying on those other staff who quite just don't know that, this package offers them a very simple model to how they can start to work in that way, because it's not natural for everybody. So I guess that's what we've tried to do, is create a package that's nice and simple and easy, that will really help those frontline workers who perhaps haven't got that depth of knowledge, skill and experience. So we can really try to make sure we mitigate these behavioural and psychological symptoms. So thanks everybody for dialing in. And again, if any other questions crop up after this event, I'm sure you can get in touch with us, and I'm happy to link with anybody and share more research for those who are interested.
Perfect. Thank you very much. It's 10 to the hour, so hopefully everyone's got a short break until their next Zoom or Teams or in-person meeting. So thank you very much, guys. Bye now.
Cheers, Jonathan. Thanks, everybody. Bye.